Thank you for the opportunity to talk today. I'm going to be doing a brief talk about kidney cancer, which is really geared for patients to understand what the kidney is, what we see when we talk about kidney tumors, an overview of some treatments, but really this is kind of kidney cancer 101 for the patients. Again, thank you for the Judy Nicholson Foundation for sponsoring this event. So first, what is the kidney and what does it do? The kidney is an organ that is bean-shaped that sits in the back of the abdominal cavity in an area called the retroperitoneum. It's in charge of filtration and excretion of blood and waste and toxins. It's in charge of regulation of fluid status and hormone production, as well as regulation of pH and osmolality. You can see by the picture here, it is a bean-shaped structure. On top of the kidney is something called the adrenal gland, which also creates hormones and regulates a lot of other body conditions. You can see by the picture that there's a major vein that runs through the abdomen that attaches to the kidney. That vein is called the vena cava, and the red structure, tubular structure, is the aorta, which is the major artery of the abdomen. You can see that the kidney is attached to these very large vascular structures, and the kidney, because of its filtration and excretion processes, accounts for approximately 20% of the blood flow every minute. You can see on the inside of the kidney, on the image on the right, that this is the area called the renal pelvis, where we see some tumors that can occur. These are tumors, most of the time are urothelial cell tumors, which are closely related to bladder tumors. In the meat, or this pink area of the kidney, is where we see typically our primary renal cell carcinomas, of which there are many, many types. So when people are diagnosed with kidney masses, what are the options? Well, you can actually have primary or secondary type tumors. Primary tumors typically account for the majority of renal masses that we see. These primary tumors can either be renal cell carcinoma, of which there are many types. About 80 to 85% of primary renal masses are renal cell carcinomas. Transitional cell, or now that we call them urothelial cell carcinomas, will account for approximately 8%. And there are some benign tumors that we see in the kidney as well that are of kidney origin, and those are typically oncocytomas. They can account for 2 to 3%. There's some less common things that we also see, like angiomyolipomas of the kidney, which also are considered renal masses, not necessarily malignancies. You can also see secondary masses in the kidney. You can see both lymphomas as well as a metastatic disease. These have very routine, very standard appearances on imaging as well. So who gets renal cell carcinoma, and what are the risk factors? Well, there are about 76,000 new cases and almost 14,000 deaths each year from renal cell carcinoma. It typically has a 2-to-1 male to female distribution, and the average age of diagnosis is about 64. There are some known risk factors of renal cell carcinoma, including smoking. Current smokers have a much higher risk of renal cell carcinoma than non. Hypertension, obesity, acquired cystic disease of the kidney, and high use of some NSAIDs, aspirin, and acetaminophen. There are also some environmental exposures, including asbestos, cadmium, and gasoline, which have been associated with renal cell carcinomas as well. There are some genetic syndromes that are also associated with renal cell carcinomas, which will be discussed in some of the further lectures. These include VHL, hereditary BAP1, tubular sclerosis, Birt-Hogg-Dubé, and succinate dehydrogenase, just to name a few, but there are many more than this as well. So symptoms and presentation. Most patients are asymptomatic and they're found to have tumors incidentally. The hallmark, traditional hallmark of renal cell carcinoma was flank pain, palpable masses, and hematuria, but these are actually pretty rare. Most of the masses are incidentally found, and typically if they're incidentally found, they have a better prognosis. So those that are renal masses that are incidentally found, say for example, a car accident or low back pain or abdominal pain, the 5-year survival is actually 76% compared to 45% of the patients are presenting symptomatically, and that symptomatic is either with hematuria or other such things like palpable masses or flank pain. Unfortunately, about a quarter of the patients that we see with renal cell carcinoma actually present with metastatic disease. There's some paraneoplastic syndromes that are also associated with renal cell carcinomas. The paraneoplastic typically means that there are other things that are going on that are caused by the cancer, not the cancers themselves. And that can be anemia, which is a low hemoglobin, erythrocytosis, which is an increase in the red cells. You can see liver dysfunction, which is something called Stouffer syndrome, hypercalcemia, elevated calcium levels, cachexia, which is wasting, as well as some fevers, typically night sweats as well. Diagnosis for renal cell carcinoma is typically made with cross-sectional imaging studies, CT scans, MRIs, or ultrasound. Again, a lot of times this is done for incidental purposes. Staging is then performed with chest imaging, either chest plain films, which are PA and lateral films, or CT scans of the thorax. Typically, renal cell carcinomas will spread through either lymphatic or hematogenous pathways. Lymphatic basically meaning the lymph nodes that are localized to the area of the kidney, or through the blood, and most frequently we'll see cancer that is spread to the lung based upon those blood pathways. Bone scans are indicated for patients with elevated alk phos and bone pain. Typically, there's a pretty limited role for PET scan. It depends on the type of primary tumor that we're seeing, and Dr. Thomas will get into this in her lecture a little bit, but we see a very, very limited role for PET scans in the setting of renal cell carcinomas. Now, a lot of times people ask about biopsy. It's really lesion dependent and appearance dependent, and also institutional dependent. And philosophically, it also depends on what the physician and the patient come to an agreement as well. Sometimes a biopsy can be used to rule out metastatic disease. It can also be used for staging and for treatment. For example, for patients with metastatic disease, it's nice to have histologic diagnosis in order to tailor therapy towards that tumor. In the setting of a localized renal mass, biopsy can be used also to determine metastatic disease versus lymphoma. Also to obtain primary diagnosis in patients with solitary kidneys. So there is some utility. Depending upon institution and physician, for a classic appearing renal cell carcinoma, a biopsy is not always warranted for diagnosis alone, as most of the time surgeons will operate based upon imaging and characteristics of imaging alone. Now, when we talk about renal cell carcinoma, we use the TNM staging system, which deals with the primary tumor, which is your T staging, your N staging, which is the nodal disease, as well as M staging, which is the distant metastatic disease. And putting it all together at the bottom of the slide, you can see the anatomic and prognostic groups for stage 1, 2, 3, and 4. Not to belabor this, but when we talked about those major vascular structures in the abdomen from the first slide, you can see that the T3A tumors here extend into the renal vein or branches of the renal sinus fat. The T3B tumors are into the vena cava below the diaphragm. T3C are into the vena cava above the diaphragm. So there are some staging. It's important because we typically treat by stage of tumor. And again, this is a classic difference picture of what we have for renal cell carcinomas that kind of come in all shapes and sizes. And if you look at the picture on the right, you can see we're seeing a cross-sectional image in a coronal fashion of a patient with a tumor on the left here, which is a small renal mass, approximately 2.5 to 2 centimeters. Above that, you see the spleen, which it looks like the tumor here is localized to the kidney. You can see the bean-like structure here. And on the right side, you see a normal, healthy kidney. Whereas on the right side here, you can see a very large renal mass, which looks like it's occupying most of the kidney. The left side is a normal contralateral kidney here. And you can see this is the major vein of the abdomen that we were looking at called the vena cava. And if you use your sight, you can see that there is a tumor that looks like it's extending from the kidney into this renal vein. And that increases the stage if you've got renal vein involvement. And this obviously changes the nature of an operation in terms of making sure we control this tumor, and tumor is considered to be a tumor thrombus. So what are our treatment options? Well, it really depends on the stage, as I said. So the treatment can be for localized disease can be surgery, it can be open, laparoscopic, robotic, it can be partial, it can be total. It really depends on the type of tumor. And if you go back here, obviously you would surgically treat this tumor a lot different than you would this tumor here. On the picture on the left, the whole kidney likely needs to go, including the renal vein thrombus. On the picture on the right, you could argue that you could do a minimally invasive approach or an open approach for a partial nephrectomy and spare the remaining normal kidney, of which this patient has a lot. You can also do something called ablation, where a needle is directly inserted into the mass percutaneously through the skin, and that tumor is ablated either using heat or cold. These days, the cold is called cryotherapy. Heat is either done with RFA or with microwave. We also can watch kidney tumors for two very small tumors that show minimal growth rate. Those tumors can actually be safely watched, particularly if we talk about identifying tumors in an elderly population. So there's this idea that active surveillance is also a consideration. Metastatic disease is also pathology dependent. Again, as I said, there's many different types of renal cell carcinoma, of which we'll get into later in these talks. And those can be treated with either immunotherapy of which we've got checkpoint inhibition, which is relatively new over the past decade, or using IL-2, which is an older medication that was used in the 90s and early 2000s. And you can also use molecular targeted therapy using VEGF inhibitors or mTOR inhibitors as well. And the field right now for treatment of metastatic disease is actually exploding in terms of the number of different options and the number of different sequential choices that we have to treat renal cell carcinomas as well.